I am going to cover the management of gram-negative multi-drug resistant organisms. The two most important part of the non-Enterobacteriaceae gram-negative organisms are the S Endobacter and Pseudomonas. First, I will cover about the S Endobacter. If the S Endobacter is a sensitive, the first line agents for the susceptible organisms are the broad spectrum cephalosporins, third and fourth generation like the ceftazidime and cefepime, a combination of beta-lactam and beta-lactam inhibitor, and the or a carbapenem, imipenem, meropenem or doripenem and Sulbactum. So a susceptible S Endobacter would be sensitive to all these antibiotics. Before I go ahead, I think it's important to have the definitions very clear. Multi-drug resistant, extensively drug resistant, pan-drug resistance. There was a lot of confusion about this terminology. The European Center for Disease Control and the Center for Disease Control in USA, they both had a consensus definitions which are described in this slide. Multi-drug resistant is described when an isolate is non-susceptible to at least one agent in 3 or more antibiotic classes. We use the term extensively drug resistance when the isolate is non-susceptible to at least one agent in all but 2 or fewer antibiotic classes. Similarly, the term pan-drug resistant is used when isolate is non-susceptible to all agents. So the terminology when you use this term should be very clear in our minds. There are studies published from our country where they have shown that these multi-drug resistant or the XDR, they are prevalent in the ICUs. They have spread all over India. And this is a study which was published in Indian Journal of Anesthesia where it shows that the S Endobacter species were the most common pathogen isolated from blood and lung infections. And they also showed in the ventilator associated pneumonia, this was the most common bacteria isolated from the early as well as late onset ventilator associated pneumonia. There are studies which have been published earlier where they have shown that this was one of the cohort study of 45 patients where they showed that it was associated with attributable mortality of 8% and excessive ICU length of stay of 5 days. And there are other studies which all have shown that if a person has a carbapenem resistant Acetobacter, it was associated with greater risk of death as compared to a sensitive organisms. Let's understand about the mechanism of resistance. The S Endobacter has multiple mechanism of resistance. The commonest still is the beta-lactamases. Beta-lactamase, they hydrolyze the antibiotic, and the most important for S Endobacter, the beta-lactamases are the serine and metallo-beta-lactamases. ESBLs could be there, but they are not as widespread as we see in E. coli and Klebsiella. Then there are other mechanisms also like alteration in the porine channels. So if there is alteration or the loss of porine channels, what happens is the antibiotic is not able to enter into the bacteria. Similarly, the efflux pump could be a mechanism. From the periplasmic space, the antibiotic is pushed out. So this could also be one of the mechanism of resistance. Then the other mechanism which is prevalent in the quinolones is through the mutations in the gene GYRA and PARC. So these could be the mechanism of resistance. Acetobacter can result in a variety of infections. It can result in a ventilator associated pneumonia, bloodstream infections, meningitis, abdominal peritonitis, UTI, skin, soft tissue and bone infections, or the central line infections. So it can result in any infection, nosocomial infection, which you can think of in the ICU. Let's understand a little bit about the risk factor of the colonization or infection of the Acetobacter. Most important is the stay in the hospital or in the ICU, which is a very important risk factor for the multi-drug resistant or an XDR Acetobacter. Prior colonization with MRSA, prior beta-lactam use, particularly carbapenems, prior fluoroquinolone use, bedridden status, then presence of a central venous catheter, recent surgery, patient on a mechanical ventilation, patient on hemodialysis, patients suffering from malignancy. All of these patients, these are the risk factor to develop S Endobacter. So, management of S Endobacter, which is a MDR or XDR organism, the most important is we should control the spread. We can only control the spread if we diagnose the infection very early. And we should be vigilant about these infections in the ICU if you want to treat early to prevent the spread to the other patients. Many of the previous drugs which we had discarded, they are being rediscovered and they have been found to be effective in the treatment of multi-drug resistant or extensively drug resistant Acetobacter. We have to optimize PK/PD to have the maximum effect of these drugs. We have to give combination therapy, which I shall discuss a little later. Then we have to supplement the IV or the systemic therapy with the local therapy like in the form of inhalation or intrathecally, and the newer drugs we can try in patient who is not responding. The principle of treatment of drug resistant Acetobacter is the use of one most active drug, or what we call as a cornerstone drug. Most of the time this drug is the colistin or polymyxin B. We use another drug which is called the adjuvant drug, which in vitro may not be showing sensitivity to that Acetobacter, like we use carbapenems. We use other drugs also which are not being found to be sensitive to the drug resistant Acetobacter. We have to maximize PK/PD by giving in the extended infusion form wherever indicated. Then we should give a direct drug delivery like I already said, the inhalation or in the form of intrathecally. Then we need to practice the infection control in all our patients. So what are the main therapeutic options to treat these patients? We have polymyxins, they are the most important drug, and we have polymyxin B and the colistin, which is the polymyxin E. These are the two most important drugs to treat multi-drug resistant or extensively drug resistant Acetobacter. Then the other drugs are Cyclin, minocycline, and other non-beta-lactamase antimicrobial based on the susceptibility report which you get from the lab. The limitations of all these drugs, there are many. The carbapenem resistant Acetobacter baumannii has become a concern worldwide. It's not only in India, it's all over the Asia Pacific, it's all over the world that the carbapenem resistant Acetobacter baumannii is really creating a great trouble. There is emergence of MDR pathogens which often require us to treat patient with more than one antibiotic. The other problem with colistin is the potential for nephrotoxicity, and several outbreaks have been reported in certain part of the world with colistin resistant bacteria, which is really a bad news. Then Cyclin is another drug, does not achieve a sufficient blood level because this drug gets out of the blood very fast into the tissue. So this drug should not be used or is not indicated in a patient who has got a bloodstream infection. And it is a dry antimicrobial pipeline. No new antibiotic is coming. That's really a bad news. So to summarize, if a person has MDR, the definitions I have already said, the choice would be a carbapenem and polymyxin. If an extensively drug resistant, where a bacteria is resistant to not only the different classes of drug, it's also resistant to carbapenems, the choice would be polymyxin, Cyclin, minocycline, sulbactum, rifampicin. We have to give these drugs in combination. For pan-drug resistant, where you find the bacteria is resistant to all antibiotics, I really don't know what to give. And you have to, the time is not very far, we'll have to choose what to give to our patients. So the first line drugs or the cornerstone drug, I think it's important for all of us to know a little bit more about these drugs. The cornerstone drug or the colistin or polymyxin B, they bind to the LPS or lipopolysaccharide and disrupt the outer membrane. That's the mechanism of action of colistin. There is no randomized control which address their efficacy. And in a meta-analysis of 4 studies evaluating treatment of ventilator-associated pneumonia, mainly due to Acetobacter baumannii and also due to Pseudomonas, they find that the clinical improvement rates, 20 days mortality and ICU length of stay with intravenous colistin were similar to those observed with the comparator agents like carbapenem or high-dose MP Sulbactum. The other problem with the colistin is that it has a major side effect in the form of nephrotoxicity. Neurotoxicity is another important side effect, but consists mainly of paresthesias and is relatively uncommon. Colistin dosing has to be adjusted in patients with impaired renal functions. Now, I think we need to know a little bit about the pharmacokinetics and pharmacodynamics about this drug. When you give colistin, it is given as a colistin methane sulfonate. The active drug, it has to be converted into a colistin. Most of the colistin methane sulfonate is excreted by the kidney. Very little is converted, about 20% is converted into colistin, which is an active, which is effective against the bacteria. Now, let's see in a patient who's got a renal failure. So what will happen, the other clearance comes into picture and most of the drug will be converted into colistin and there will be a increased fraction of colistin available. So one has to modify this drug in a patient who's got a renal functions derangement. There's a little bit more about dosing in a critically ill patients. So one must remember the volume of distribution of drugs in a critically ill patient is totally different. It takes about 4 to 5 half-lives to reach a target steady state plasma concentration. So you require a loading dose. If you don't give a loading dose, the effect will not come soon. So critically ill patients, you require a loading dose and which is usually a higher than what you give routinely to these patients. This is a study which had shown with the 3 million, 9 millions and 12 millions, they showed that you require a loading dose about 9 millions to achieve a steady state level of plasma colistin in these patients. Then you have to maintain the dose. The maintenance dose will depend on the daily dosing rate and the clearance of drug. It's very important that we understand the factor that do and do not influence the drug clearance, because that will determine the maintenance dose of colistin in these patients. Normally what is nowadays recommended is in patients who have moderate to severe renal impairment, that is creatinine clearance less than 50 ml per minute, the loading dose of 9 million unit and maintenance dose of 4.5 million unit 24 hours. For creatinine clearance rate less than 20 ml per minute, loading dose of 9 million unit and maintenance dose of 4.5 million unit in 48 hours. For a person with a normal renal function, the dose would be 9 million unit and 3 million unit 8 hourly. And this is another study which showed that if you increase the maintenance dose after giving a 9 million dose as a loading, as you can see in this slide, the 9 million dose was definitely was associated with the decreased mortality. This was a study which was analyzed by the Matthew Falagas, who's done really a lot of work in the colistin and the management of drug-resistant Acetobacter. Another very important factor which you should remember about the MIC levels. And there are studies to show now that if you find a higher MIC in the lab, whether it is an Enterobacteriaceae or a non-Enterobacteriaceae or what we call the non-fermenters, both have increased mortality if you find the high MIC in these organisms. So this was another study published and where they looked at whether you should give the dose in the form of extended infusion. So this study had looked at the high dose extended interval colistin in a critically ill patient, and they showed that if you use like this, it had a high efficacy without significant renal toxicity. So the dose I prescribed was quite safe in the normal patients. So this is another study where Matthew Falagas analyzed all the studies, and a systemic review and a meta-analysis was published of 14 studies, 1,229 patients, where they compared the carbapenem with the short-term or extended or continuous carbapenem and piperacillin tazobactam. They found the lower mortality for patients who receive extended or continuous infusion of a carbapenem or piperacillin tazobactam. So these drugs ideally should be given in an extended infusion form to achieve the better efficacy of these drugs. Then the doses, the Europe and the US, there are different doses described, but one needs to give the doses of these drugs according to the weight of the patient. You know, a little bit about why you don't want to give a colistin as a monotherapy. Because if you give colistin as a monotherapy, bacteria can develop to resistance to colistin through mutations, and such mutation is inherited and it will be transmitted to the other patients. So there is always a trend, and it is recommended that you should give a combination. We know the benefits of the combination therapy, like to increase the likelihood of adequate empiric antibiotic coverage before the drug susceptibility testing results are known, to decrease the risk of emergence of drug resistance, to improve outcome in multi-drug or extensively drug-resistant infections. This is a study which was a cohort clinical study of 250 isolates, and they found 52.3% isolates were polymyxin only susceptible. And this study showed that when you combine colistin with meropenem, had a better outcome than any other combination with colistin. So colistin with meropenem is considered one of the most important combination in treating these infections. There was a study which was published by Balaji from India, where they not only reviewed all the studies, they also showed that the MIC of meropenem was 4 microgram per ml, colistin had 0.38 microgram per ml, but when you combine, the MIC dropped to 0.12 microgram per ml. So it shows there was a synergy with the meropenem and the colistin. So this study concluded the meropenem seemed to be a better choice, showed better synergy. It's a smaller molecule. It can enter into the target organism in sufficient amount, even with a little increase in membrane permeability, which is facilitated by colistin. Safer in higher dose, less neurotoxic. Unlike imipenem, porin loss is not a major problem with the meropenem. See, when you combine the colistin with the meropenem, the permeability of this drug because of colistin is increased. That is one of the mechanisms which is proposed, the reason why colistin plus meropenem show a better outcome than the colistin alone. So to summarize about colistin, it has been proven to be a life-saving antibiotic for patients with MDR and XDR infection. It is important that colistin is dosed appropriately to minimize the risk of resistance, as it is the last line agent against MDR gram-negative bacteria. Loading dose range is based on the ideal body weight, should be administered intravenously over 1 to 2 hours. Maintenance dose can be given as IV infusions. If the GFR is less than 50 or 60 ml per minute, dose adjustment is required. The colistin doses equal or even higher than the daily dose is given in a patient with normal renal functions, in patient on a continuous renal replacement therapy, because both colistin methane sulfate and colistin, they are removed by CRRT. What I am trying to say is the patient on CRRT, one has to be extremely careful, because one has to give a normal doses rather than a decreasing doses, particularly patients who have a normal renal functions and are given CRRT you need to give a higher or a normal doses in these patients. Then the other drug which is really emerging recent past is the minocycline, and many of these Acetobacter bomini have been found sensitive when this drug is given intravenously. Although there is a very limited experience, there are retrospective case series which have shown that minocycline was used multi or extensively drug resistant Acetobacter infections, predominantly VAP, and they reported successful clinical and microbiological outcome in most of the patients. How to diagnose that the minocycline is sensitive? If you find the patient isolate is showing sensitive to tetracycline, you can imagine it will be sensitive to a minocycline. This was one of the analyses again by the Matthew Falagus on all the studies which had been published on the minocycline, retrospective studies, most of them regarding doxycycline for the treatment of 180 doxycycline as well as minocycline for 185 isolates of Acetobacter bomini. 156 patients were available, 65% were respiratory infection. In 86% tetracycline were administered in combination with another agent. The dose of minocycline and doxycycline was 100 milligram intravenously twice daily with a 200 milligram as a loading dose. And they found clinical success was achieved in 120 patients, 77% of 156 patients, and microbiological eradication was also obtained in 71.3% of these patients. So, and very few adverse events. So, this analysis showed that this is a drug which could be useful in a definitive treatment of Acetobacter bomini infection. The other drug which we have been using for some time is the broad spectrum antibiotic, is the TG cyclin. It also covers the carbapenem resistant Enterobacteriaceae and the Acetobacter. It's a drug which is not effective against Pseudomonas, and in a today era of resistance, we tend to use this in a serious infections. USFD warning is based on the various meta-analysis, and they said that you should not use this drug on a patient who's got a bacteremia or sepsis and ventilator associated pneumonia. The bacteremia, I have already said, this drug goes out of the blood very soon, so you will not be able to use this drug for bacteremia or a severe septic patient, and ventilator associated pneumonia, because it has not been found to be effective in this infection. This I have already described. The TG cyclin increases all risk mortality among patients with a hospital acquired pneumonia and a ventilator associated pneumonia in one of the studies. Then recently there was a the paper published from Italy where they showed that if you use a higher dose than the routine one in a multi-drug resistant gram-negative infection, they showed the better outcome in these patients, and the higher dose was associated with better outcome than the standard dosing. So probably we could use a higher dose of TG cyclin in treating Acetobacter infections. Again, I am saying that don't use this drug for a severe sepsis and a ventilator associated pneumonia, because this drug has not been found to be effective. But if you have to use in desperation, you can use it as a third add-on drug with colistin, meropenem and TG cyclin in these two conditions. Then the other drug which has been used is a Sulbactum, and if you want to use this drug, some of these the organism could be susceptible, and if you want to use in a proper dose, that's about 9 to 12 grams per day in combination with the other antibiotics. Then a word about the specifics, like if you have a multi-drug resistant or extensively drug resistant pneumonia due to Acetobacter, you supplement colistin along with carbapenem, that's the most common combination, along with inhaled colistin. It has been shown that the only side effect which is noted is some of the patients may have bronchoconstriction. But if you want to use it, use in a proper dose, which is 1 to 3 million units per nebulization every 8 to 12 hours. And if you're using inhaled polymyxin B, the dose is 5 lakhs units or a 500,000 unit twice daily, which is an alternative agent. If a patient has bacteremia, as I said, this is not the drug, but if you have to use only as an aspirate as a third add-on drug. Meningitis, carbapenem enters into the CSF, particularly when inflammation of the meninges is minimal. Carbapenem resistant isolates have shown that polymyxin have been used in these patients with some success. When colistin is administered intravenously, there is a moderate penetration of inflamed meninges and spinal fluid level reach approximately 25% of the serum levels. So this can be supplemented with the intraventricular or intrathecal. The dose is 0.75 to 7.5 milligram colistin. So you could give a very high dose, a good amount of dose intrathecally or intraventricular, and you should give, and you keep on repeating the CSF of the examination to know whether the patient is responding to your treatment or not. Then skin and soft tissue, of course the debridement would be the major issue in these, and you should do that. If you want to use this drug, you give it 10 to 14 days or until local sign of infections have resolved. But if patient has osteomyelitis, you should give it 4 to 6 weeks of these drugs. So summary about the resistant S Endobacter. Infection with MDR S Endobacter are associated with high mortality rates. The use of single agent is not adequate. You should use with combination. Although there are no definite clinical data that combination improves outcome, but there is definitely smaller studies which have shown that the second agent, carbapenem, minocycline, TG cyclin or rifampin. Rifampin will not be used in a country like India, but these other drugs have been shown to improve the outcome in these patients. I'll now discuss in brief, more or less the treatment is similar like S Endobacter, in brief about another non-Enterobacteriaceae multi-drug resistant gram-negative bacilli, and that's Pseudomonas. Pseudomonas is a gram-negative aerobic bacilli. It causes severe infections in the hospital-acquired or the immunocompromised patients, is often antibiotic resistance, and which complicates the choice of therapy. It is associated with a high mortality rate. If the Pseudomonas is a susceptible organism, it is sensitive to the antibiotics, you have a lot of choices. Ticarcillin clavulinate, piperacillin tazobactam, or ceftizidime, ceftriaxone, cefepime, aztreonam 2 grams every 8 hours, or fluoroquinolone 400 milligram every 8 to 12 hours, carbapenem, aminoglycosides. So for a susceptible, you have a lot of choice, and the choice will depend on the site of infections, local resistant rate of Pseudomonas, prior culture data, patient allergic history, and hospital formulary. So all these will determine the choice of antibiotic in these patients. The resistance among the Pseudomonas, both intrinsic and acquired, is important to consider when you select an empiric or directed therapy. Combination therapy is indicated in certain high-risk patients and in severe infection. Antimicrobial therapy should be prompt, as delayed therapy, like in any other infection, is associated with poor outcomes. All infected catheters or devices should be removed. When rate of resistance is low, you can give a monotherapy, which is actually not prevalent now, particularly in India or abroad in most of the nosocomial infections. When the rate of resistance is higher, you need to use a combination with an anti-pseudomonal fluoroquinolone, aminoglycosides, or in a resistant, you use colistin, which we'll discuss a little later. If combination therapy is used, two agent with different mechanisms should be used. Use a beta-lactam as a first agent and an aminoglycoside as the second, provided there are no contraindication to its use. Aminoglycoside should be avoided in patients with renal insufficiency. This is all I'm talking about, a susceptible organism. Combination therapy in a susceptible organism is always used when patient has sign of severe sepsis and septic shock, neutropenic patient with bacteremia, burn patient, in other setting where the incidence of resistance to the chosen antibiotic class is high. So in a susceptible organism, which is really not prevalent nowadays, use in combination therapy in these 4 conditions and where you expect the resistant rate is higher. Now let's talk about the MDR or XDR Pseudomonas. There are various risk factors like the intensive care unit stay, like in S Endobacter, bedridden status, invasive devices, prior use of certain antibiotics, including broad spectrum cephalosporins, aminoglycoside, carbapenem, fluoroquinolone, diabetes, patient undergoing surgery. Then as far as the treatment of these is concerned, again the colistin and polymyxin B are still the cornerstone drug for the MDR or XDR bacteria. Second drug, meropenem or doripenem, amikacin if it is sensitive. Phosphomycin is another drug which is being evaluated and is coming, which could be effective in treating these organisms. This was a case, an unusual case, where they published toripanem along with phosphomycin, and they showed a good outcome in patient of multi-drug resistant or XDR Pseudomonas. There are various algorithms which have been suggested based on the MIC level, and they have shown that combination, when you treat the Pseudomonas or the S Endobacter, should include the combination should include, depending on the organism, its susceptibility profile, the site of infection of the patient, and probability of achieving antibacterial activity by attaining PK/PD targets, by optimizing the dosages, thinking of toxicity profile, and potential for synergism should be considered when you choose a combination therapy. So I'll end this talk that send appropriate culture, get empiric therapy right, diagnose is very important, send the culture, be in touch with your lab and get the diagnosis. Always ask them to give you the MIC and the breakpoints. You need to use a cornerstone drug, which is colistin and multi-drug resistant Acetobacter and Pseudomonas, along with adjuvant. De-escalate if you isolate a sensitive organism, and you should give for adequate duration, it is recommended that non-fermenter you should treat at least 14 days. The best time to plant a tree was 20 years ago, when we had sensitive Acetobacter and Pseudomonas, and the second best time is today. That's a Chinese proverb about the antibiotics. So prescribe antibiotic wisely and precisely. So I will just talk about for every patient that before starting antibiotic, one should think, what is the site of infection? Is this infection community acquired, hospital acquired? Does he have exposure to healthcare environment in the past 3 months? Is the patient immunocompromised? Does my antibiotic target the suspected pathogens? Does my antibiotic reach the target site? Have I sent the necessary samples? What is the gram stain showing? Start effective and antibiotics promptly. Appropriate microbiological testing should be done. Local and national policies should be adhered to, because the sensitivity in one ICU differs from another hospital. And always document, give a shortest antibiotic course. If it is a sensitive, don't go on prescribing antibiotic because patient is on a ventilator or has a line. Whatever is the policy, national or international recommendation, follow that. Then you should monitor the drug level wherever indicated. Single dose surgical prophylaxis should be done, and always consult the infection expert wherever indicated. It is important that once you started empirical treatment, review antibiotics at 48 hours once you get the culture sensitivity report, and de-escalate. Stop antibiotics, discontinue antibiotic, please, when they are not indicated, when infection is not evident, when it is a non-infectious. Use susceptibility data to substitute, change antibiotics, and try to move to a narrowest possible spectrum. Switch to oral therapy wherever it is indicated. In MDR, XDR may not be feasible most of the time, but if patient is all right, you should consider outpatient parenteral antibiotic therapy because the cost of staying of these patients in the hospital is very high. Thank you very much.